buccal mucosa to get accepted in a second stage only, we can catheterize the urethra by Gabale.
I didn't get the question exactly. Fistula or is it stage surgery?
No, at the same time as buccal mucosa.
You require to bypass everything. So catheterization is mandatory.
Can you put silicone catheter at the same time of buccal mucosa grafting after fistula excision?
Oh,
Actually,
like an inlay.
unless there is a stricture, we wouldn't use buccal mucosa in case of fistula, first of all. And if we are doing a stricture and fistula, then it depends on individual case whether we want to stage it. Like yesterday, I had shown a stricture with fistula. So we laid open, did the allowed it to settle, and used the buccal mucosa at the second sitting with the tubularization. So if it's a stricture fistula, I would lay open the stricture and the fistula and then allow things to settle. After 6 months, we do buccal mucosa and tubularize in the same sitting. That would be safe. I would prefer to use stent.
Next question is, what are the options to close the fistula at root of penis with completely failed previous urethroplasty, and now patient is passing whole urine via the fistula?
Yes, it means that there is a stricture of the distal urethra. So I suggest to lay open after the urethrogram. You decide how much segment you want to lay open, either the entire segment or a part, and then you do in a staged manner using buccal mucosa urethroplasty and do the fistula closure. Thank you. Yes, please.
Excellent presentation, sir.
Thank you.
How long can we keep the PTFE ureteral stent? How long, in your experience, how long have you kept?
12 days we can keep, no problem.
And one more thing I wanted to ask, out of curiosity, sir. You use buccal mucosa, you use full thickness Datos
Yes.
as a graft. If there are restrictions at the donor side for staged BRCA's repair, in stage 1, have you ever tried split thickness skin grafting if the urethral bed is not good?
No experience.
No experience with that.
Yeah.
Okay.
Because as I said, I have experience doing the tubularization of previously done split skin graft, but it becomes very hard, so non-pliable like.
Okay.
Then you have to take a wider width and dissect more,
Okay.
and the chances of dehiscence are very high.
And sir, in the case which you just mentioned,
Yes.
when you opened it, did you see there was some secondary contracture in that grafted site, which was split thickness skin graft, which was used on the urethral bed, in the urethral bed?
Yes, there was contracture as well as lot of what you can say resistance to tubularize.
Okay.
It had healed. Probably there was some raw area which had healed, but it refused to tubularize. That was the issue.
Thank you, sir.
Thank you.
Thank you, sir. May I, thank you, sir. Post-distal segment with the distal segment.
Whenever there is a stricture, it is essential that you lay open the entire stricture, because if you keep any residual stricture, you are likely to have cicatrization later. So you go much beyond the doubtful area. And in fact, there are satellite strictures when we do the urethroplasty, and sometimes when you do a scopy, they are missed on urethrograms and you need to lay open. So it is better you lay open entirely, put buccal mucosa and do the tubularization. Because anyway you are able to do it primarily. There is no need to wait. If you are only having a stricture, you do dorsal inlay and tubularize, same sitting.
Dorsal inlet to present same setting.
Thank you, sir.